its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. Many types of liver diseases share symptoms such as swelling of the liver, yellowing of the whites of the eyes and of the skin, fluid buildup in the abdomen, and all kinds of other things. There's also hepatitis A, B, and C that enters this picture as well. This evening we're going to have some physicians answering your questions about liver disease. We will also talk about prevention and different treatment options. And as you know, this is a live program, so get on the phone and give us a call, 881-0013. The medical students from the Texas Tech Paul L. Foster School of Medicine will be here to take your calls. And we have Victoria Diaz here, who is a medical student first year. And then we have Aaron Pines, who's medical student second year. So they're going to be taking the phone calls from you. And again, a live program. So when do you get to ask live questions of the docs? Tonight you get to do that. This evening's program is underwritten by the Hospitals of Providence. We also want to thank, once again, the Texas Tech Paul L. Foster School of Medicine for providing the medical students, and as always, the El Paso County Medical System and Society for bringing this program to you. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. We are going to be talking about liver disease and treatment options this evening, and there are all kinds of new things on the horizon that we're going to be speaking about. Again, the questions that you can call in, 881-0013. We are streaming live on Facebook, and you also can watch the show back again on kcustv.org and also EPC MS, which is the El Paso County Medical Society.com. Because a lot of times we just shoot questions out and it's so hard to catch it all. With me today, we have Dr. Robert Lurie. Did I do that right? Who specializes in radiology, and Dr. Alex Reznichenko. Been practicing for 10 minutes, and he is our general surgeon here this evening, and Dr. Ruben Ramirez, who is our gastroenterologist this evening. So I told the people at home what your specialty is, but the nice thing to do is, so they can get to know you a little bit, what does it mean to be a person in radiology? Mm-hmm. And that way they can kind of see what the specialty is and they know what questions to ask.
Sure. So radiology has a bunch of different subspecialties in it. I'm specifically an interventional radiologist, which means I specialize in doing minimally invasive procedures that are guided by imaging. So the main modalities we would use is ultrasound or X-ray or CT to guide minimally invasive procedures that are inside of a patient's body while visualizing the procedures on a screen.
Okay, so there's some diagnosis that you do, and then from there also treatment
Correct.
That you do. Okay,
Correct.
Nicely explained. So the surgeon, everybody thinks, oh, I know what a surgeon does, but within today's show and what we're talking about this evening, how would you like to explain what you do all day, every day?
Well, I'm a hepatobiliary surgeon, and I'm a transplant surgeon who specializes in liver transplantation, kidney
Specializing
transplantation.
in liver transplantation, okay.
I've also been in general surgery practice for almost 30 years, so I've been exposed to all types of surgical procedures.
Okay, and we're going to talk quite a bit about transplantations this evening, when is it necessary, lists and all that good stuff, so I'm very happy that you're here. And then we have Dr. Ramirez, gastroenterology. That's a mouthful. What do you do all day, every day?
Yeah, so it's same as my colleagues, radiology, and in general medicine. Medicine has evolved over time, and it has become so subspecialized that within this specialty you have several branches. In the world of gastroenterology, you have, for example, general gastroenterology, which includes treatment, diagnosis of conditions, endoscopy in general. Then you have the branch of advanced endoscopy, which is other colleagues that are trained specifically to techniques endoscopically. And also you have the branch of transplant hepatology, which is also, in addition to being a general gastroenterology, in my case, I'm also a transplant hepatologist. And in this case, we focus more on the follow-up, diagnosis, management, and treatment of patients with advanced liver disease in general.
I think it's just fun to say transplant hepatologist. I think you should just walk into any career day at any school and say that's what you are and have everybody stare at you for a while. But it's something that's very important. What I'd like to do before going into some of the specialties that we have here is talk about the function of the liver just physiologically. And since you're the gastroenterologist, Dr. Ramirez, I'm going to have you address that. And then we'll talk about diseases and then when people need to have transplants, and then hepatitis C might be something that we'll talk about later.
Yes, yes, Catherine. So, I mean, just to put it in general terms, and for all the people watching the show, is instead of getting very scientific, the liver is in charge of helping the digestion and metabolism of everything we consume, basically. So, we drink water. If we drink another beverage, we eat protein, carbohydrates, fat. The liver is going to be involved in the metabolism of that. Now, the function of the liver is basically producing, helping in the metabolism, but also producing proteins for our nutrition and for us to have what in medicine what we call homeostasis. So basically helps us with coagulation proteins, with immunology, with our defenses. And that is why when the liver starts having or is diseased and having problems of the function is when patients express those symptoms that we're going to talk in the future.
Exactly. And that's a great transition then to Dr. Lurie of what types of issues can people have with the liver. And I feel like let's just start with maybe the two most common right now, and then we'll just kind of go from there, because I know there's all kinds of issues, but we're talking about liver disease. And is that something that people are predisposed to through genetics, or is that something that is environmental? Is it something that is a health habit, etc.?
Well, I can give you my perspective from a radiologist, what I see. I think the clinical practice would be, what Dr. Ramirez sees in his practice. He's actually seeing the patients presenting with liver disease. I'll see them on the spectrum of what their actual imaging looks like.
Okay.
And what you see in the liver is a lot of scarring. Basically, there's a lot of inflammation, chronic, long-standing inflammation that's causing a lot of scarring of the liver tissue, and the liver tissue ends up losing its function.
And the scarring is caused by, I know that when we talk about alcoholism, talk about Hep C in general. So let's talk a little bit about alcohol, just so we can get that on the table. And what does that physiologically do to the liver?
Well, I'm gonna
Dr.
yield to
Ramirez?
Dr. Ramirez here.
So,
Just throw it your
yes.
way.
So, to expand a little bit more on your question, so there's different causes of liver disease. And as I explained to the patients in clinic, no one is different than the other. The liver doesn't really discriminate. You can have alcoholic liver disease, you can have fatty liver disease, viral hepatitis disease, and in reality, the liver will undergo the same process. So in the United States, the most common cause of cirrhosis currently and need for liver transplantation is hepatitis C.
Is it? Okay.
But with the new therapies that we have available, specifically over the past 4 to 5 years, this is decreasing, and now what is going to become is projected to become the #1 cause of cirrhosis and need for liver transplantation is going to be fatty liver.
Okay.
So what I tell to the patients is, when you hear fatty liver from your primary care doctor, from radiologist or neurosurgeon, because they removed the gallbladder and they saw that the liver was infiltrated by fat. Fatty liver is not a simple diagnosis. It's a serious condition. It's the #2 cause of liver disease in the United States currently. And then we go to alcohol, and then we go to other diseases, genetic conditions, autoimmune processes. But in reality, like I said, regardless of the type of liver disease you have or you're presenting with, if it's chronic in nature, eventually it will progress. So a very simple way to explain the mechanism of injury is basically you have something that's causing daily injury every second, every minute to your liver, and progressively is accumulating scar, as Dr. Lurie has mentioned.
And is this something people can prevent, fatty liver? Is it the diet? Is it just the way that they're doing things? Maybe we can touch base on that.
Correct, and we can expand on that. But yes, I mean, there's many things that we can do as individuals to try to prevent it. It has a genetic component. It's very similar to diabetes in that sense, but there's things that we can do to manage it and prevent progression.
Okay. So and let's take fatty liver for a little bit. And again, I know the surgeon, you're going to get all kinds of questions in a little while. So Dr. Lurie, let's talk a little bit about when you are diagnosing somebody and you are looking at a liver, radiology, looking at a liver, and there's scar tissue there. Fatty liver, is that the same thing? As you have scar tissue from a fatty liver as well as from hep C? Do you see it differently from your perspective?
So what we see with liver disease in radiology, we can actually see the deposition of fat in the liver.
Okay.
And then that can be the predisposition for developing cirrhosis, which is the scarring of the liver. And so when you get the scarring of the liver, this, what I see on the imaging is a buildup of what's called, basically the liver gets very scarred and you get portal hypertension, which is a very scientific sounding word, but basically the blood flow into the liver is getting blocked because it's hitting a wall of scar tissue. So there's a lot of resistance. The blood flow is unable to really travel very smoothly through the liver. So you get a backup of this pressure, and people end up developing a lot of ascites in their abdomen. Their spleens will get very big because the pressure backs up into the spleen. And they'll also, because the blood can't get through, the blood tries to take alternate routes, and they'll develop varices, which are abnormal blood vessels that wouldn't be there if the portal hypertension isn't there to begin with. So those are likely to cause very significant risks for bleeding for patients, which can be life-threatening. So
these are all symptoms that you're talking about.
Correct.
And Dr. Ramirez, I'm going to throw this back to you again for a minute. So the symptoms that Dr. Lurie is talking about, when people don't think that they have any issues with their liver, and they're just not feeling well, or they're getting swollen, or what are some of the symptoms, because you're the gastroenterologist, they would come see you. What is it that people complain about kind of in the beginning stages and then gets worse and worse? And then we'd like to talk about Dr. Reznichenko. And there we go, Reznichenko, took me a bit. And then we're going to talk about when transplantation is an option. But in general, let's talk about symptoms, what people complain about, and just think about what the audience at home might be questioning.
Correct. Exactly. So first of all, I think that one of the most important points about this is that we have to realize that an early inflammatory process to the liver, even if it's chronic, and it has been there for a year or 2 years, is not going to show any evidence of clinical symptoms. They may be very subtle. So you could be having
problems and not have a clue that you're having problems.
I tell my patients, just to illustrate this, I may have cirrhosis right now, and if I don't go to my primary care doctor, get blood work, I'm not going to realize it. Then I get blood work, and I realize that I have had chronic liver disease for a long period of time, and now I'm showing just those changes, subtle changes in the labs or the radiology imaging that are showing or demonstrating that I already have advanced scarring in the liver. So again, the initial and most important point for our audience is early liver disease will not let you know. So basically, how is it that we can figure out? First, if you have any risk factors, just to touch real quick on hepatitis C, if you're in a certain birth cohort, what they call the baby boomers, and you have been born between 1945 and 1965, there's a worldwide recommendation by the World Health Organization to have at least one screening test for that. If you have any other risk factors for viral hepatitis, like hepatitis B or C, tattoos that have been performed at home or on unlicensed places, history of IV drug use. If you were born to a mother with hepatitis B or C, you should be screened. I mean, those are just healthcare workers, actually. We should be screened because we're at high risk from needle sticks. That's in the setting of viral hepatitis. For fatty liver, if you have risk factors of diabetes, high blood pressure, what we call in general metabolic syndrome, it wouldn't be a bad idea to talk to your primary care doctor and say, how is my liver doing? And if you have been told, because somebody obtained an ultrasound or your liver tests were mildly elevated, that's something to look into.
So pay attention to that.
Exactly.
Exactly.
And of course, I mean, if there's a risk factor of alcohol consumption, if it's chronic or high dose alcohol consumption, it wouldn't be a bad idea to have at least an annual checkup and make sure.
And often this is a blood test. You know, whatever the screening blood test would be, there would be something that would show up in there that says something's a bit off.
Yes,
for the most part. Because it's not like a liver screening.
Exactly.
Okay.
And yes, and again, I mean, for hepatitis C, it's easy because it's a very specific blood test that if it's positive, it's positive. And you know the answer. For fatty liver and most of the other conditions, is not as straightforward.
Okay.
So it's a complement of tools. And again, I mean, to explain it in a simpler way, I say we as physicians have a toolbox, right? The toolbox includes our lab work, our radiation imaging, I mean, our radiation, a radiology tool, clinical, of course, I mean, your signs, what you were talking about,
Right.
symptoms. And when you combine everything, that's when you can get to a diagnosis of a disease that is not so straightforward
Gotcha.
as liver disease.
Okay, so what I want to do, I want to include Dr. Reznichenko into the conversation. So I am going to ask you, when is it a time when it's time for you to be on a transplant list? So what does the liver have to present? How is that person feeling? What is going on within the body where it's time to have that serious conversation, where it's time to get you on a transplant list?
Well, I think before we'll start talk about it, I would like to talk a little bit about MELD score, which stands for Model for End-Stage Liver Disease, which is a score we use now to allocate the organs for our recipients. And this score includes several criteria, 4 criteria from the blood test, which reflects liver function, kidney function, and some electrolytes in the blood. A normal person has a MELD score of 6. So liver is initially, as Dr. Ramirez just explained, is a forgiving organ. It takes a long time when patient develops cirrhosis. And patient with cirrhosis could be very well compensated, which means MELD score is not high. What we want to see usually, that when MELD score is 11 or higher, that this patient referred by primary care physicians, by gastroenterologists to transplant center for evaluation. Why we use MELD score for allocation? It's just to be fair, because there is significant shortage of organs in this country. On average, we do about 7,000 liver transplants in the United States and about 17,000 patients on a waiting list. There's not enough livers for everybody. So in a fair way, the liver goes to a patient who has the highest MELD score.
Okay. And normal is 6, you said?
Normal is
For the
6.
most
So
part,
MELD
okay.
score basically is a projection of your survival or your chances to die in the next 3 months. So
In the
higher,
next 3 months?
yes.
Okay.
If your MELD score is 40, your chances of survival is probably close to 0.
Goodness.
And usually these patients who are 35 and higher, they most of the time in a hospital could be on a ventilator. They could be critically ill. They're encephalopathic. They, coagulopathic. They're very sick patients. So when your MELD is 11, you could be fully functional. You could be at your work. You could do whatever duties you do on a regular basis. But we still want you to get evaluated for transplant, because evaluation for transplant will take some time. When you will get on the list, you will have some sort of insurance that if you will get sick for whatever reason, and these patients with cirrhosis, they don't have reserves enough, any respiratory tract infection, any UTI, whatever, can push you and your MELD score will jump to 30, but you're already on the transplant list.
Okay.
So maybe that program will help our community to realize that the earlier you will be evaluated for the transplant, the better.
And there's also the waiting. Like you said, there's a shortage of organs. Now, there's something that's beautiful about the liver, that there could be a partial transplant of the liver. That's like or is that the kidneys? Did I say that wrong? So
No,
could you do
you're
a
correct.
partial liver transplant?
You're
so I'd
correct.
like to explain, whoever would like to take that on, because I think it's interesting, because a person can be a live liver donor as well as, you know, somebody receiving part of that liver. And to me, the question is, it's just fascinating to me, is how a partial liver can help the old liver, who's not doing so well, do well. And Dr. Ramirez, since you're nodding your head, you get to take that question.
I can,
Let me
Or
tell you
you
that
can tag
Dr.
team it. There you go.
Reznichenko,
can
it
take
knows
it.
all about
Okay,
that.
great.
so the beauty of the liver is can regenerate. So you can transplant half of the liver, part of the liver. In a child, you can transplant just lateral segment. And with time, it will regenerate and take all the functions. So the truth is that in this country, we don't do a significant amount of live donor transplants for a variety of reasons. If you go to countries like South Korea or Japan or China, they do gazillion amount of live donor transplant. We do slightly more than 300 in the entire United States. So,
And why is that?
well, it's, you know, we utilize disease donors more than in Asia. I think it's maybe a cultural thing. They believe that what's dead is dead, and they progress to some centers in Seoul and South Korea do about 450 live donor transplants a year.
Interesting. Okay.
So we do mostly disease donors, but some centers in this country, advanced centers, do live donor transplants as well. And that usually in adult population, it's we take in right side of the liver. In a child, we take in left lateral segment.
Okay.
In a pediatric centers, most common scenario when the child is sick and the parent, mom or dad, donates part of the liver.
Okay.
So you got to realize that live donor transplantation is the magnitude of that, because you need to take part of the liver from completely healthy person, put this person at very high risk of having issues, complications, and take the bad liver from diseased person and put this part into diseased person.
And is the entire bad liver removed?
Correct.
The entire liver is removed, and then a partial liver then is put into, and that's
we
where
call
the
it
regeneration comes in.
orthotopic transplantation, means that we removed organ from area and put new organ in the same area.
Okay.
Orthotopic liver transplantation.
Okay. And so the risk factors of the donor, and what I would like to do is maybe encourage people to do some live donations if they can, but the risk factors for the donor of a partial liver transplant, what are those? Like, what is the downtime? Maybe take us through a bit of a case study there.
Well, the risk factors, it's like you're doing a resection of the liver. You're removing
Okay.
part of the liver. It's a very big operation, which, you can have significant blood loss. You may have a bile leak. It's a big incision, and it's a risky operation.
Yeah.
There was some
But
cases
you could be
being
giving life to
described.
someone, which is
Correct.
yeah, very nice. I'd like to talk a little bit. I want to talk about cancer of the liver in a moment. However, we did touch base on fatty liver a bit ago, and so I have got many questions already from the audience about fatty liver. Number one, and I know we just said diet, but we didn't talk about what that means.
Correct.
So the question here from the audience is, how can I prevent my fatty liver from getting worse? So this person's someone who's already been diagnosed, or it's already in the idea. So let's talk about getting away from fatty liver. We can talk about sweeteners too, like I think high fructose corn syrup goes straight to the liver, and it just, there are certain things that you can do. So maybe touch base on that, Dr.
Yes,
Ramirez.
definitely. So fatty liver, just for the audience to know, is it's an epidemic in the United States. It's in the world, but
And
in
in
the
El Paso too, I understand,
In the
right?
United States, there's calculated anywhere from 20 to 40 million people affected with fatty liver. And this is from Prevalence studies. Now, it all depends on where you get the information from, but those are the ballpark numbers. So it's a major problem. It has a genetic component. I mean, there has been several studies, both in the United States and Asia and some other countries, where There's some mutations that have been associated with higher predisposition. Having the predisposition doesn't necessarily mean that you're going to express the disease, but with higher predisposition. So it's a multifactorial disease. That's a complexity and what makes it so difficult to manage, because you have the genetic predisposition, and on top of that you have the environmental factor that plays a role.
And then the lifestyles, that's what I'm trying to get to, is what can people do with their lifestyle to help with this condition?
So basically fatty liver, opposite to what most of us think, is not a problem of how much fat you're eating.
Okay.
It's a problem of carbohydrates.
Okay.
It's a problem of carbohydrate metabolism. It's how your body is assimilating excess carbohydrates. So again, just to put it in simple terms, is carbohydrates is the gasoline to our bodies, where we get energy, right? So,
and let's be specific about carbohydrates. Let's talk about potatoes, rice, bread. Be specific so when people are listening, they're like, okay, I know I'm eating a lot of tortillas.
Exactly. When I write the list to my patients, they get surprised because I include oatmeal, cereals, tortilla, of course, cookies, bread, potato, pasta, the pasta component of soups. Rice, I don't know if I have already mentioned rice. So basically, it's a large part of, specifically in this geographic area, it's a big part of our diet, of our daily diet. You wake up in the morning, have a bowl of oatmeal, a toast, and coffee. You think that's a healthy breakfast.
Well, there's fiber in toast. That's what we've been told all of our lives. No, but this is specifically why I want to talk about this, because I'm 51, so growing up, it's like, oh, eat all your fiber, eat all your breads, eat your cereals. So there is a shift that needs to happen, because there is this epidemic, as you said, in the United States, depending on the diet, because there have been teachings, and you do shows like this. It's like, well, what's prevention mean? And it changes. 10 years from now, it's going to be different as well.
That is
so. I now remember the old school food pyramid. On the bottom were grains. What are grains? Carbohydrates.
Exactly.
So that's why I want to get specific about that. So if people can, and maybe let's take away what not to eat and throw into the equation now what we should eat, and try to just eat a little bit more of this and that and the other, and maybe you won't have the desire for so much bread.
Correct. So basically a good start when I have the initial evaluation of a patient in clinic is increase your protein intake, decrease your carbohydrate intake. So just to give examples, because sometimes it's better to give examples to the patients, is in the morning, you have your oatmeal today. Next day, don't have oatmeal. Have a boiled egg, and the following day, a couple pieces of ham. Then you have already skipped a couple of days without eating the same thing every day, which is carbohydrates. The excess carbohydrates is basically what we store.
Right.
But we don't store it as sugar. We don't store it as carbohydrate. We store it as fat. And people that have that genetic predisposition or risk factor are the ones that develop fatty liver from accumulation, plus the inflammatory component of it, which is what over time will progress.
Exactly.
So again, increasing protein, and I tell them, increase a little bit of your fat intake, but decrease your carbohydrates. So it's basically just balancing that.
Nice.
And inverting that pyramid, as you said.
Okay. Dr. Lurie, I'm going to talk to you a little bit about cancer diagnosis in liver, since you're the guy that looks at the liver and sees what's going on in there. And I don't know if there's any preventative factors with cancer. That's one of those that's a loaded question that will be hopefully answered in 100 years from now. But when you are looking at a diagnosis situation, what is it that you see as a cancerous liver versus a fatty liver or a liver that has scar tissue?
That's a really good question, actually. That's very pertinent to what I do. What we try to do with imaging is make the diagnosis of hepatocellular carcinoma, if we can, on imaging. Because if you can make the diagnosis with imaging, you can spare somebody the risks of going through a biopsy.
Right.
Biopsies are typically very safe, but there is a little bit less than a 1% chance of life-threatening bleeding that's associated with a biopsy of the liver. And when you start running, that sounds like, oh, it's very safe, and it is, but when you start doing many, many, many of them, they become significant. These numbers become significant. So anytime we can make the diagnosis of hepatocellular carcinoma with imaging, that is always the preferred way. If there's any doubt or question as to whether it's hepatocellular carcinoma or whether it's a lesion that's originating from somewhere else, because there's a lot of metastatic disease that goes to the liver, basically cancer from somewhere else in the body
Right.
that's going to the liver, and you don't know what it is, and that will require a biopsy. But making the diagnosis of hepatocellular carcinoma should be, replaces the need for a biopsy.
Okay. And are there, and this is the hard question, because there's not really a liver cancer screening. So are there any symptoms, and I'm just throwing this out to anybody who wants to take it, are there any symptoms when somebody, well, there's just going to be liver issues, and we need to figure out what the issue is, whether it's fatty liver, whether we've got another type of liver issue. So I talked about symptoms earlier in the show, but are there liver cancer symptoms? Does that make sense? The question I'm trying to throw out there, Dr. Ramirez, since you're nodding, you get to have that one. That's what you get for nodding.
I have to stop
I'll take
nodding. I'll look away. Now, so, well, actually, there's a very specific guideline as to who we need to evaluate for liver cancer.
Okay, excellent.
And it's based on imaging, as Dr. Laurie has mentioned. So everybody that participates in liver world or as a physician, the screening in general is, and actually this was changed just recently on the guidelines in January, it's a combination of a tumor marker plus abdominal ultrasound. Now, depending on the guideline, if you're talking about, I mean, the recommendations from the medical societies from Europe or the United States, it goes from 4 to 8 months. So repeat an ultrasound every 4 to 8 months.
Okay.
In general, we do it every 6 months. The goal of that is to detect the cancer when it's early in stage, to try to treat it and hopefully achieve what we call remission, which would be the equivalent of cure.
And the treatment is chemotherapy? I'm
That's
assuming at
where
this
Dr.
point it's
Laurie
not
can-
it's not
Dr.
surgery.
Laurie and Dr. Resnichenko can
Okay.
expand on that.
Resnichenko, just because I like saying your name now and you haven't talked in a while.
I would like to add to what Dr. Ramirez said, that if patient is on a waiting list, we do some screening for
Okay.
hepatocellular carcinoma, patient with cirrhosis, because no matter what causes cirrhosis, cirrhosis by itself acting as a precancer. And that's kind of important point to make before discussing the treatment options. So for liver cancer, we have several options. They're not just chemotherapy. Some of them are curative options, some of them not. So two most common curative options today is a liver resection or surgery, which is removal of the part of the liver with the cancer. And the other option is liver transplantation, which is removal of entire liver with a cancer and replacement it with a healthy liver. Each of these options have limitations, obviously. So if we're talking about resection, this patient should be very carefully selected. We need to make sure they can tolerate this operation, number one. Number two, we want to make sure that the remnant of the liver or part of the liver which will be left in the patient's body will be enough sufficient to support this patient's life. And here the important point comes up that if patient has advanced cirrhosis, usually and end-stage liver disease, usually big resections are not recommended because these patients cannot tolerate these procedures.
Right.
So as far as transplantation, it's not just very simple thing, you just can transplant anybody you want. With cirrhosis, we follow certain criteria for that, depending on the size of the cancer, how big it is, how many total lesions in the liver, and another important part is how aggressive is the tumor. Generally speaking, we do not want to transplant patients who have highly aggressive cancers,
Right.
because they do very poorly. So when they have so-called vascular invasions on the pathology, it's not a good sign. So what we do today, and Dr. Ray will add to this, we use bridging therapy if patient has cancer and cirrhosis. We cannot transplant them right away. Usually they wait a certain amount of time, usually 6 months in most of the centers, when they will get so-called exception points and their MELD score will increase. But during this time, we do so-called bridging therapy, which is not curative, but it can cause, I would say, cancer, put it under control.
Okay.
It's either so-called transarterial chemoembolization or internal radiation therapy.
Okay.
When we selectively put, and Dr. Lurie would talk about it, either radiation beads or chemotherapy beads around the tumor, try to kill it.
And I think there's a lot of talk in that, and it's September, so it's Prostate Cancer Awareness Month too. But you do hear a lot about beads or prostate cancer seeds, just radiation seeds that sometimes are implanted in that area. Is it the same concept as what that I've just heard about for years, is radiation seeds that are implanted in the prostate? I know it's tiny compared to the liver, but is it the same concept that we're talking about?
Yes, it is. And
Okay.
I think Dr.
Yeah,
Lurie
so
will.
I think what I just want to step back for a second, that it's really important, patients with liver disease and cancer, that there's this multidisciplinary approach, that there is a team of doctors
Right.
that is thinking about what their specialty is, what their approach would be to solve the problem, and they put their heads together and then they decide, like Dr. Reznichenko, the gold standard for treating a cancer would be resection, but he says the patient's not a good candidate for that. So that's when I would start to move into the picture. And really there are two main ways that we do treatments. And the goals are to really always to extend the length of life as well as the quality of life.
Exactly.
Some of our treatments can be curative sometimes. And as he said, basically buy some time or bridge to a point in time, because the resources are so scarce, to get to a transplant.
Okay.
So the main treatments that somebody might come see me for would be a microwave ablation, which means basically, like I said, as I started to discuss at the beginning, I'm using imaging, usually ultrasound or CT, to guide a probe through the skin, less than a 1 centimeter incision. I can actually watch a metal probe go into the tumor, and then from the tip of the tumor, microwaves get emitted, just like the microwaves that are in your kitchen.
Beautiful. This is exactly what I was talking about. Okay.
And so the waves, these waves, they actually cause the cells in the liver or in the tumor to oscillate or move back and forth, and that friction generates a lot of heat. And when you get to a certain temperature, the cells will lyse or pop and cause cell death. So that's one modality we could use, and the other would be using a catheter. So just like a neurointerventionalist might put their catheter into the brain and try to remove a blood clot, or an interventional cardiologist would try to remove a clot from a coronary artery, I would put my catheter into the arteries that feed directly into the liver.
Got it.
And as Dr. Reznichenko had mentioned, we can select vessels that are specifically going to tumors. And those vessels, we can then put beads into them that are either loaded with chemotherapy, that we can deliver high doses of chemotherapy directly into
Very
the tumor.
targeted, yeah.
With sparing the rest of your body, as to getting it in an IV. Or the other method would be to, again, beads, but they're loaded with radiation.
Right. And is this something that after a while do the beads then lose their potency and they are removed later? Or is it the radiation that is presented? Ablation, I love ablation. There's just so many beautiful things. Just take it out. So when that's the case, are the radiation beads then later removed?
The beads stay there.
They stay there.
The
Okay.
radiation, it decays over
Okay,
time
got it.
and is no longer active. As far as the people hear the word radiation, some people get very anxious when they hear that. But literally, the cloud of radiation, it's so selective, and the distance that the radiation emits from the body, it's the cloud of radiation is very close to the body.
Well, I love what you do because it is so specific and so targeted. And again, radiation intervention. So you're doing the intervention in there. So you're going specific to those areas. And I think that more and more, I mean, we do this show 2 or 3 years from now, it's going to be even more specific. And that's what's beautiful about this. We are about at the 17-minute mark of the show ending, believe it or not. So what I want to do is address quite a few of these questions here from the audience, and I'm just going to throw them out and see if we can answer some of these. I do want to give a shout out to whoever is watching and feeding information on Facebook Live. That's something that KCOS is doing relatively new, and so thanks for that. The question from the person Facebook Live: can non-alcoholic fatty liver, and we haven't talked about that, because what's fatty liver again? Can that be cured, or can it just be controlled? And Dr. Ramirez, you get to take that question.
Yeah, so non-alcoholic fatty liver has two very specific components. The one that has fatty infiltration in the liver, found either on an ultrasound or a CT scan, but there's no active inflammatory component, versus the one, and that's called, in medicine, that's called NAFLD, non-alcoholic fatty liver without inflammation. So, but then you also have the other component. There's the NASH component, which is, in medical terms, non-alcoholic steatohepatitis. That is the one that you have accumulation of fat in the liver the same way as the other patient, but in your case, because of genetic predisposition, it's causing an inflammatory process. And yes, once you have the diagnosis, like I said, it is a multifactorial disease, so you have to work very hard on your lifestyle modifications, because the genetic component you cannot remove from the equation.
And then sugar, I'm just going to ask quickly about sugar input and or sugar substitute input, because we talked a lot about carbs, which turns into sugar, but then there's the direct sugar too. So diet sodas versus real sodas, if you can just take a second or two on those. And then I want to transfer into some of the hepatitis, A, B, and C's too, because we really haven't touched base on that yet.
Correct. So in general, any soda, but regular soda will cause a large accumulation of sugar in your body, and that will transfer to fat.
Okay.
So if you are a Coke drinker, which in our geographic area, that's very popular.
Yeah.
And you have been told to have fatty liver, that's something that you probably should cut down at least.
Maybe don't supersize it.
Exactly.
Okay. Nicely said. So let's talk about hepatitis. There is hepatitis A, B, and C. And again, I'm throwing it out to whoever wants it, but we have to touch base on that because there's some new treatments too and cures that haven't been the case for a while. So Dr. Miros, I'll throw it to you and feel free to jump in, but let's start first with what is hepatitis, period, as a disease, and A, B, and C.
Okay, so hepatitis, real quick. Hepatitis just means inflammation of the liver. It's a Latin, so it can be from alcohol. You can have alcoholic hepatitis, fatty liver hepatitis, or viral hepatitis. Now, talking about the group of viral hepatitis, A, B, and C are different type of viruses that affect the liver. So A, in general, is an acute virus. It's something that the common said, well, you're eating tacos, street tacos, or something that is contaminated. And that's usually self-limited.
Okay.
You will get an acute inflammatory process, but usually within a period of 30 to 45 days, your liver will resolve. Very few.
So that goes away on its own.
That goes away on its own.
You cannot take my street tacos away.
Exactly.
Okay, gotcha.
Now the thing is, only a very, very, very small fraction of those patients will progress to acute liver failure.
Okay.
Which that's where transplant actually plays a role.
Right.
But in this case, it's not as common. Then you have hepatitis B. The major difference between hepatitis A versus B and C is that A is acute. B and C can present as an acute process, but a large percentage of the patients that have been infected with B and C will progress to chronic liver disease.
Okay.
So we'll go into that. So,
okay.
And the difference between B and C is that B cannot be cured currently.
Hepatitis B cannot be cured currently. Okay, so hepatitis C can?
Can be cured, yes.
Sorry, I have a cold. But yeah, okay.
So hepatitis B is a little more complex, so there's different stages of disease. You have active disease, latent, inactive. So it's a little more complex as far as medically to treat, but it can be controlled really well. The medicines that we have can be, most of the time we control the patients beautifully with medications, but we know it cannot be cured. There's spontaneous cure on a very small percentage of patients, but it's more spontaneous than actually predicted cure.
And then hepatitis C
now,
is?
We have hepatitis C, which is virus that it can have the acute presentation, but mostly you don't even realize you got it. You may have some flu-like illness or symptoms. And then 80% of the patients that have been exposed will develop the chronic condition.
And so this is the baby boomers that you said. If you're a baby boomer, just go get it checked out.
Correct.
Because there is a cure.
And
that is relatively new, correct?
Over the past 4 or 5 years, fantastic therapies with average, I mean, talking about the different medications we have, average, they're taking the medicine for 8 to 12 weeks versus in the past it was an injection. Now it's oral medication. 8 to 12 weeks with chance of cure, average 97%.
And 10 years ago, there was no chance for cure, or at least I can't say
it was
chance.
Really, it was really
yeah,
low. It was really low. Depending on ethnicity, African American individuals would get cure rate of 20 to 30%, Hispanics around 40%, Caucasians around 50%. But now it's 97%. So it's
and that's really exciting. So the diagnosis of hepatitis C, is that a simple blood test?
It's the one that I told you that nowadays, in the past, no, but nowadays if you have hepatitis C, it's not such a big deal. It's even sometimes simpler than to treat hepatitis B or fatty liver because we can cure it. And it's a simple blood test. Okay.
I'm glad we talked about that because I know we're running out of time. We have other questions here from the audience. This is a Facebook Live question too, what are the symptoms of stage 4 cirrhosis? So it doesn't, again, my disclaimer is this is all the information we have. We do the best with what we can. So would you like to,
Sure.
I have to read your name, Reznichenko. We practice so much, I just have to have some fun with it now.
You're doing good.
Thank you, sir. Thank you so much. So stage 4 cirrhosis.
Well, stage 4 cirrhosis and stage liver disease, these patients, again, they could be compensated, but when decompensation occurs, they become jaundice. They develop a fluid in the belly, a cholestasis. They develop varicose varices. As a matter of fact, bleeding from varicose varices is the most common cause of death in stage liver disease. They develop extreme fatigue and muscle weakness. They can develop fluid in the chest. So this, they can develop hepatorenal syndrome because kidney, like a little sister, following big brother liver and becoming sick too. So all of these things we need to look for. That's why I want to go back to the beginning of our discussion. We don't want to wait until this happens when it's sometimes too late. And we want these patients with cirrhosis being evaluated early and be placed on a transplant list.
This is a hard question to ask, and I don't know if there is an answer. Being placed on a transplant list, what may or may not be an expected time frame? I guess it depends on the score that you were talking about earlier. And then from there, what could we be looking at? Months to years? And I'm throwing that out to anybody who wants it.
Well, if your MELD score is low, 11 or 12, you probably will, unless you have a cancer, you probably will not be transplanted anytime soon.
So within that list, there's also a way of ranking within the list and the waiting
we have
list.
this list. We divided in blood groups because we, transplant in most of the time, compatible blood groups, AB, O, AB, and AB. So it's 4 blood groups, and we have on each blood group a list of patients. And again, the liver goes to the highest MELD score. Furthermore, liver distributed not just in this particular center, they're distributed regionally. We here belong to Region 4, which is Texas and Oklahoma. So the livers will be distributed in the Region 4. If we have a patient here in El Paso with MELD of 30, and we have a liver locally, but there is a patient in Houston with the same blood group with MELD of 35, the liver will go to Houston. But because of that that distribution, yes.
Question here from the audience. We were talking about alcohol earlier, and the question from the audience is hard alcohol worse for the liver compared to beer? And so I'm throwing that out. Yeah, see. So not only did you nod at me, you're like, hey, I'll take that one. Okay, Dr. Ramirez, that one's yours. So let's think about a Sunday afternoon watching football. You're going to have your bourbon, you're going to have your beer.
So The answer is no. There's no difference.
There's no
I mean,
difference,
actually, when
okay.
you talk to sometimes when you ask the patients and you ask, "Do you drink?" Some patients say, "No, I don't drink. I just drink beer, no alcohol." There's no difference. It has to do with dose.
Right.
So meaning, the higher number of drinks you have, it's an increased dose, and also concentration. Of course, I mean, the concentration of the alcohol, but in general, it has to do with the amount, the volume of it. Alcohol is alcohol. Now, there's low volume alcohol, but what happens with a lot of the individuals that drink low volume alcohol, they drink several
Exactly.
of those.
So if you're
right?
looking at 4 beers versus 1 bourbon, is that about the same,
It's about the same.
Massimanos?
Yes,
Okay.
exactly.
Okay, so that was the question here from the audience. We are at the 7-minute mark, so what I'm going to do is stop questions from the audience for a minute and go to all 3 of you and see if there's something that we have not talked about yet that you'd like to talk about, or something that maybe we touched base on that you really want to get across. So Dr. Lurie, I'm going to ask you first.
Okay, I think really what we've started to develop, actually, the group of us here, Dr. Ramirez, there's another physician like myself, Dr. Reznichenko, there's another hepatobiliary surgeon, Dr. Cox, and pathology gets involved, and we actually have a multidisciplinary liver board that we discuss individual patients, and we all bring our expertise to the table.
Okay.
And
I'd like you to expand on that, because I know there's tumor board, so this is liver board.
Yeah.
Tumors are involved, but at the same time, it really is all about the liver. So let's talk about the different disciplines at the table.
well, basically, oftentimes, Dr. Ramirez has a patient that he's seen in clinic, and he'll present a clinical scenario. I'm the radiologist. He'll present the labs, the findings, everything about the patient. And then I'll present imaging. This is what I see. And then we might have a lesion that we think is hepatocellular carcinoma. And then we start to talk as a group with a surgeon, interventional radiology, gastroenterology, what is the best thing to do.
Okay.
And
how often do you all meet? Does it depend on the caseload, or?
I would say every 2 weeks
Okay.
on average.
Very nice. That's great that you do that. I love it. Just in general, it's nice when teams get together. Dr. Reznichenko, how about you? Is there anything that we haven't talked about that you'd like to talk about?
Yes, I would like to talk about El Paso.
About El Paso?
Yes.
Okay, let's talk about El Paso. You're such a serious guy. And it's like, this is a great smile coming out of you. I like this right now.
I'm Russian. I'm serious.
Yes, you are. Reznichenko, yes.
Well, El Paso has highest mortality from liver disease in Texas.
I read that, and I wasn't sure if it's something that I misread. Is there a reason that we know of why that's the case?
I'm not sure. Maybe Dr. Ramirez, he was born here. He knows better. But I think it's a combination of things, combination of everything. NASH, fatty liver, alcohol, closer to the border. I'm not sure, but the mortality in El Paso is the highest in Texas. So we charged actually to build a liver transplant program in El Paso. That's why I came here to this town.
Okay.
And that's our ultimate goal, to help patients here not to go to be transplanted to Houston or Dallas or San Antonio or maybe even out of state, but have the service done here.
So that's a nice call too for organ donations, all organ donations, but liver donations, again, I think it is one of the few, if not the only, that you can do live tissue transplantations. Is that true? Or I guess there's a few, but liver is the one that I think about all the time. So get yourself registered. Texas driver's license, you can do that at the DMD. How about you, Dr. Ramirez? Anything that you want to touch base on?
Yes, 2 points to expand on what Dr. Reznichenko was just saying. Yes, El Paso has the highest mortality. Nationally, mortality reported by CDC, Center for Disease Control, in 2016, it was 10. Liver mortality was 10 out of 100,000. In Texas, 13 out of 100,000. in El Paso is calculated around 20 to 22.
And we
out of
don't know
100.
why.
Well, there's factors.
Okay.
Hepatitis C.
Yes.
There's studies that have shown the prevalence along the border of the United States and Mexico. Hepatitis C is higher prevalence. So as I've told you, hepatitis C is the #1 cause of cirrhosis.
Okay.
Second, fatty liver. We have Hispanics have a lot of Hispanics. There's about a study was showing that about 30% of their group that had active fatty liver were Hispanics. So it's higher than African Americans, and it's a little higher than Caucasians too. So fatty liver is a big problem. And also, of course, lifestyle, alcohol intake, and things like that. So there's factors that contribute to a higher prevalence in our community. The second thing that I want to mention is going to Facebook like question that was asking, how can I know if I have early liver disease or cirrhosis, stage 4? Where stage 4 by definition is cirrhosis.
Gotcha.
Stage 4 by definition is cirrhosis. Now, there's a wide spectrum of how somebody with stage 4 can present. I may have cirrhosis. I don't look like I have cirrhosis right now. And there may be somebody that has cirrhosis with all the symptoms. So just don't forget, if they have told you that you have liver disease, just go find your doctor.
Go find your doctor and start. So we're talking very specifically, because I like saying this to the people at home, less carbohydrates, less tortilla stuff, because we all love to.
Yes.
And if you can, a little bit less on the alcohol. I wanted to give a shout out to the Texas Tech medical students for a moment. They run a free clinic here in El Paso, which is really great. And the free clinic obviously takes a little bit of money. And we have Aaron Pines smiling and waving at you, and also Victoria Diaz. And they have a fundraiser. It's a 5K run that they're doing on October 28th. And all of that money goes to that free clinic, which is on Alabama Street, so that people can go there, no cost. They go, I think it's Saturdays and Sundays and other times of the week too, but the students help run that clinic. In fact, the students are running the clinic. There are doctors there that are there as well. But again, you can call you can call, I don't know who to call. Sunday, October 28th. Actually, call Texas Tech, Paul F. Foster School of Medicine. They'll have the information there. But again, October 28th at 8 o'clock in the morning. And it's on Scenic Drive, which would be absolutely beautiful. And again, this was on Facebook Live. I'm not sure how much time we have. And I'm sorry about my nose and my way I'm speaking this evening. It's just one of those days. But if you want to watch this show again, you can watch it on Facebook, and you can find KCOS TV. You'll see it there. And you can also watch it on kcostv.org. Find the word watch, go to programs, go to local programs, and you will be able to find the El Paso physician there. And also, the place that gives this to us each and every month, we've got the El Paso County Medical Society, and that acronym, epcms.com. And you can go there and just look for the El Paso Physician logo. And when you're there, check us out, and we appreciate your questions. I hope you have a very good evening, and thank you three for being here this evening.
Thank you.
I'm Catherine Berg. Good night.
Go grab these.